The axial coccyx is the same pretty much as the sacrum, except that you're angling 10 degrees caudally instead of cephalad. So you're going to still center 2 inches above the pubic symphysis, and you're going to use a smaller cassette because the coccyx is very small. Your marker is going to be low and outside again, and you will tell the patient to hold their breath, suspend respiration. One thing to watch out for again is if the tailbone is really painful for the patient, they will tend to roll one side or the other and have some rotation. It really hurts them to lie flat, so be sure and support their knees again. And this is where the issue of whether the patient has gone to the bathroom or not has an effect. It's really difficult to see through that area because the coccyx is so small if there's a bunch of fecal matter or gas or bladder's full, things like that. So once again, you're centering mid-sagittal plane, 2 inches above the pubic symphysis, 10 degrees toward the feet, caudal. So to make sure that your images are good, you want to make sure you have good collimation. Your markers are out of the way, down on the right side or the left side inferiorly. You want to make sure you see the entire coccyx, that it's not superimposed by the pubic symphysis. That's really easy to happen if you don't have your angle correct. And no rotation is very important. The lateral sacrum, patient's going to be lying on their left side typically. Their hips and knees are going to be flexed. You can put a cushion between the patient's knees to help them be a little bit more comfortable on their sides. You want to be in a true lateral position, so your pelvis and your shoulders need to be lined up straight lateral. So your midconal plane is vertical to the image receptor. 40 inches once again. Now your marker is going to be anterior mid-sacrum or lower, so it will be visible. If you put it posteriorly, it needs to be superior to be out of the way, because you don't want it to end up right in the sacrum or in the coccyx below. Just remember, if you put it posterior, you may burn it out with your exposure, especially if you haven't used the lead blocker behind the patient in order to absorb some scatter. So really the best place to put it is anteriorly inferior on the image receptor, or on the patient up by the hip bone. It'll be in some anatomy, but that's okay. You need to have it forward and out of the way, and the attenuation of the beam that happens with the body will help you still have your marker visible within the anatomy. So according to the book, you have a perpendicular CR at the level of the ASIS and to a point 3.5 inches posterior. So Jeff says 3 to 4 inches posterior to the ASIS, and the book is pretty specific, 3.5 inches posterior to the ASIS. Use your best judgment by the shape of your patient, but just so you know, it could be anywhere in between there. And this is what your image is going to look like. You want to be sure you have the sacrum. L5S1 is going to be at the upper part of it, and you want to be sure you see the entire sacrum without it being cut off. So you can see where be really careful with your marker. It can either go up here if you're careful and you think you're not going to burn it out, but anteriorly up here or below is best, and that way you're for sure not going to have it in the way. So lateral shielding for the female patient, you can see this can be right across the top. So if you've got your corner there by the hip covered with a lead blocker, but you've put your marker down here, it's not going to be in the picture. So just keep that in mind. Wherever you shield the patient, make sure your marker is visible. And here's that posterior shield, the lead blocker on the table to absorb scatter. Lateral coccyx is pretty much the same position. The difference in this is going to be 3.5 inches posterior to the ASIS, but you're also going to go 2 inches inferior to the ASIS to get the coccyx centered in your image. The book says a 6 by 8 inch collimation because the close collimation will improve your visibility. Once again, those bones are really tiny, so you want to be really careful to make sure you absorb as much scatter as possible with that posterior lead and your collimation being small so that you don't miss any of the details. Holding the breath again is important. And you can see how good this looks when you've got it just right. One of the things that people get confused about on these is the greater sciatic notches, and they will label them as the acetabulum. The acetabulum is lower and more anterior, so just be sure that you don't get confused when we're going over the anatomy and at the site rotations, the site visits, that you call those the acetabulum because that is the greater sciatic notch. Evaluating the images, you want to be sure that you see as much detail as possible and there's no superimposition, there's no rotation, things like that. So if you use that lead blocker behind the patient, you're going to have much more visible bony detail. Projections for the SI joints, you're going to do an AP axial and AP oblique views, RPO and LPO. Patient supine, for the CR, you're going to angle 30 to 35 degrees cephalad. Males, you'll use a little less angle, females, a little more angle. The central ray enters the mid-sagittal plane 1.5 inches above the pubic symphysis or 2 inches below the ASIS. You use 8 by 10 or 10 by 12 and include both SI joints. They want to see both in the same image. So center mid-sagittal and include both joints. 40 inches again, your markers are going to be lateral, either superior or inferior. You don't want them in the SI joints, so I would suggest inferior might be a better option. And also holding the breath. Axial projection, you can see once again you're going to have your median sacral crest is going to be centered and not rotated. And they want to see the joint spaces up at the top here. They want to see those fairly open. So if you have your angle correct, it should look pretty good. The Ferguson view, this is how you evaluate to make sure that you've got this correct. You should be able to see the L5S1. You should be able to see the sacroiliac joints here, especially at the top. You should see some pretty good detail as well. Oblique views of the SI joints. As I told you earlier, the angles of the SI joints between the sacrum and the ilium are 25 to 30 degrees. You have to be really careful not to over-rotate the patient because you will not open those joint spaces and the radiologist won't be able to see through there, and you'll have to repeat it. Think of a log roll like you do with an oblique L spine. If you roll the shoulder and the hip together and you put a sponge underneath to support the patient, that will keep them in alignment and also keep them equally rolled shoulder and hip wise. Use a sponge that'll help to support them in the back. You don't really want to bend their knees, or the thigh might get in the image, or it might cause the patient to roll their hips too far. So try to keep the legs relatively straight. So your central ray is perpendicular and it enters the patient 1 inch medial to the elevated ASIS, so that you're focusing on the joint that is furthest away from the image receptor, or the elevated side. So in the book, the collimation says 6 by 10 inches, but Jeff says 3 by 5. It's really not a very big joint, and they want to see detail. So the smaller collimation that you can use, the better. And 3 by 5 should be plenty to get that on there. So I'm sure you'll see in lab exactly how that works. Once again, markers are low and lateral, and hold the breath for the patient. The patient will hold their breath. So this is what your open SI joint is going to look like, and this is what your patient is going to look like. Perpendicular central ray, 1 inch medial to the ASIS is where you're centering, 3 by 5 collimation. So you want to see proper collimation and the open joint space with minimal overlapping of the ilium and the sacrum. Pathology, the sacrum, typically you're going to, in the sacrum and coccyxes, you're going to have fractures from trauma, car accidents, motorcycle accidents, things like that. If you look really closely on this view, you can see just below that, this arrow, right down here are where the sacral cornua and the coccygeal cornua are in alignment. Now, coccyx fractures and dislocations are really, really painful. You can be injured from falling and landing on your rear and on your tailbone and sacrum, and they can either dislocate or fracture, either one. And you can see on this view, this is dislocation, and up here, this one's a fracture. It's a little harder to see, but you can look real close and you can see the fracture. They have these great cushions for sitting when you have a tailbone fracture, when this is open in the back. So it takes the pressure off of the tailbone. Leaning forward when you sit will also help. Coccyx can also be injured and fractured during childbirth. Quite painful, and a lot of times the action of going from sitting to standing or standing to sitting is just as painful as sitting on the broken or dislocated coccyx for too long. Pathology in the SI joints, you can get fractures. Typically you're going to have a fracture that corresponds, one up here and opposite corresponding lower ischium fracture as well. These are what some of the repairs look like. They're going to use screws and I don't know what all these things are to link everything together, because the articulations are all out of alignment when something fractures or dislocates. You can see here where the ligaments are torn or ruptured, how the pelvic or pubic symphysis gets out of alignment as well. Anything injuries to the pelvis, SI joints, and the sacrum and coccyx can be very painful and get the whole pelvis out of alignment. And so my last parting thoughts are: protect your tailbone, find a nice soft place to sit.